I'm going to tell you a little bit about some of the work that I've been doing looking at weekend effects and out-of-hours effects on outcomes of care. And really, I got into this whole research question through personal experience, through relatives who had perhaps suboptimal care after being admitted on a Friday evening. And it was this that started my journey around this particular topic. So, without further ado, I'm going to talk a little bit about the background and the sort of literature out there, then talk about some of my work and how that relates to other people's work, and then perhaps at the end, if we have time, have a look at any evidence of an impact of a move to 7/7 care. So I have been causing a little bit of trouble over the last few years in this research. It seems to have quite a high media profile and resonates with members of the public. And the idea is to tell you now a little bit behind the research behind those headlines. So when I started looking at this in about 2008, 2009 or so, it was a bit of a mixed bag of work done on this. There was a classic paper by Bell, which was a Canadian paper looking at 3.8 million admissions, and they found an effect in a number of specific admissions. 23 out of the 100 causes of diagnoses that they looked at. And this is a very oft-cited study, mainly because of its size of looking at 3.8 million admissions. There was another paper, so that was Canada, another US paper looking at acute myocardial infarction. Again, they found a significant weekend effect, around about just under a 10% increase in mortality for acute myocardial infarction. Slightly smaller study here, just under 250,000 admissions. And then there was we looked around for European examples of work into this, and this is a Spanish paper, again often cited, much smaller study this time, 36,000 admissions, and just confined to Spain, to a single hospital in Spain, in fact, and they found a non-significant increase in the odds of death, but if they looked at 2-day mortality, they found a significant increase. So there's a few studies that seem to show an effect, but and there were other studies in neonatal mortality, a single study in Scotland, which was the only UK study that we could find, found no effect, but it was only looking at a single hospital, and a study looking at intensive care and the clinical database that runs from that found no evidence of a weekend effect. Or at least they found an increase, but it was accounted for by case mix adjustment. So I decided to look at the data that I had access to, which was hospital episode statistics. This is a national administrative data set collected on every single patient admitted to NHS hospitals in England. And I looked at a year of data for 2005-06, which was the most recent data that we had at the time. And very much like the original Bell Canadian paper, we looked at a range of diagnoses, 50 diagnoses. We made adjustments for age, sex, socioeconomic deprivation, comorbidities, and subdiagnoses within those diagnoses. And we looked at the odds of death calculated for admissions at the weekend compared to admissions during the week. So our study was slightly bigger than the Canadian study. We had over 4 million admissions with over 200,000 in-hospital deaths. And if you just looked at the crude mortality, we did find an increase risk for in-hospital death for weekend admissions. We looked at 50 diagnosis groups, and in 17 of those 50 diagnosis groups, we found a significantly higher odds of deaths, including stroke and acute myocardial infarction. We also pooled all the data and looked at the overall odds of death, and overall, if you were admitted as an emergency case at the weekend, your odds of death was around about 10% higher than if you were admitted during the week. Here's our table full of all our diagnoses. And we estimated that if you applied the risk of dying during the week to the weekend admissions and looked at the difference in what we observed and what we might expect, that this accounted for, well, our estimate was around about 3,000 excess deaths occurring in patients admitted at the weekends for that year. Now, interestingly, I was at a conference last year in Edinburgh where there was lots of talk about independence, and I thought I'd just pull this in just to be topical. But this is Alex Neil, MSP, who is the Cabinet Secretary for Health and Wellbeing, and in his speech, he actually said, "We have no problems with weekend mortality. That's all south of the border. We've got all that sorted," which was very interesting because as he was speaking, I Googled on my phone and pulled up this BMJ publication, which suggests that it's a similar analysis to ours, but it suggests that the odds of death at a weekend compared to weekdays is around about 1.4, so 40% higher at the weekend compared to weekdays, which was interesting, very political, this Scottish independence business. Okay, so back to my study. However, one could criticise our study for looking at 50 diagnoses. Well, you're bound to get some significant results. But it's unlikely that you would get such a high number of significant results. We had 17 diagnoses with a p-value of less than 0.001. So very unlikely to be due to chance. And the overall result, as I said, pooling all the data, was around about a 10% increase in the odds of mortality. Now, what we did notice is that there are fewer admissions at the weekend. So the case mix might be possibly different. It might be just more severe patients who are admitted at the weekend, and the less severe perhaps leave it until Monday. Now, we attempted to account for the kinds of illnesses and diseases that people were admitted for, together with their comorbidities and their age. And accounting for that, we still found this excess. But we can't rule out that the case mix might be different in patients admitted at the weekend. We weren't able to look at deaths out of hospital. We could only look at in-hospital deaths. So perhaps if you managed to follow these patients up beyond their stay, the difference might have evened out. However, Nick Fremantle, I think, from UCL, has done a similar study to ours, but he's managed to link out-of-hospital deaths to in-hospital deaths in his analysis and still found the same effect. So the next bit of work we did was looking at elective surgery. Now, one of the reasons to moving to this was perhaps because of the criticism around the inability to adjust for case mix, or the perhaps inadequate adjustment for case mix at the weekend. This idea that perhaps patients admitted at the weekend might be more severely ill. So I decided not to look at a weekday contrast, but looked at mortality by day of the week and looked at elective procedures. So again, I used hospital episode statistics, looked at all acute and specialist English hospitals carrying out elective surgery over a 3-year period. And we took our definition of planned surgery as those kinds of operations that you would expect to appear in an operating theatre, using a list that we'd already defined in previous research. We excluded day cases. The risk of death in day cases is practically 0, so we wanted to take those out of the equation. And in this study, we were able to follow up patients to see whether they died out of hospital. So this looked at 30-day deaths, not in-hospital deaths. And we were able to adjust for the various things that we were able to adjust for in administrative data to take into account differences in case mix. And this is what we found. So we had over 4 million inpatient admissions for elective procedures, nearly 27,500 deaths. So mortality from planned operations in England is pretty low. It's a fraction of a percent. So that's just something to bear in mind when I tell you about some of the relative differences in mortality. It's a very low mortality rate. So we compared mortality for procedures carried out Monday, Tuesday, Wednesday, Thursday, Friday, Saturday, and Sunday with the Monday rate and worked out the odds of death on each of these days. And we found that if you had your operation on a Friday, you had a 44% higher odds of death than if you had your operation on a Monday. Now, at the weekend, this difference was even bigger, but looking at the mix of operations, the kinds of planned operations carried out at the weekend, there was clearly quite a difference between operations carried out at the weekend and during the weekday. So I'm perhaps a little, I find the 82% perhaps a little bit more difficult to digest. But what was really, this is the picture we published in our BMJ paper. So this is Monday, which is the reference rate, and you can see a gradual climb in the risk of mortality till this leap on a Friday and this even bigger difference on a Saturday and Sunday. Now, there are problems with this analysis. It's based on administrative data. We can't, again, adjust completely for case mix, although we did look at 6 specific procedures, as well as looking at the whole mix of procedures, and found some significant results, I think, out of 4 of those 6 procedures. Our data was perhaps 2 or 3 years old, so things may have changed more recently. And as I said before, the actual mortality for elective procedures is relatively low, a fraction of a percent. Some people criticised our benchmark for using Monday, saying, well, that makes things look artificially high. I'm not sure as I can agree with that criticism. What's the explanation for this seemingly increased risk of death on a Friday? And our hypothesis, really, that it was post-operative care, perhaps not picking up issues or problems following the operation. And that's backed up by a little bit of further analysis. We also published figures not just for 30-day post-operative, but 2-day post-operative deaths, and that difference on a Friday compared to Monday was even greater for short-term outcomes. And also, I suppose if you think that it's weekend care, that if you have your operation on a Sunday, you might expect, because your post-operative period comes over on Monday or Tuesday, where you've got full staffing levels or so, that you might expect a dip. And actually, when we looked at the data, we did find that if you had your operation on a Sunday, mortality fell slightly. Still high, but was lower than on a Saturday. Now, the other possible suggestion for this that was suggested in a rapid response was that, if you are a new consultant starting at a hospital, you will almost invariably be given the Friday afternoon list by default. So is it perhaps that junior doctors, not junior doctors, but junior consultants, are working more on a Friday? So previous stuff is published. This isn't published yet. But if you look, because we have on our hospital episode statistics the GMC number of each consultant doing the procedure, we're able to match that GMC number with the number of years that they have been on the specialist register, and so are able to have a sort of a proxy for consultant experience. And you can see that the usual mix, this is junior doctors, this is junior consultants, this is 3 to 10 years, and this is over 11 and over years of experience. And perhaps there is a little peak on a Friday there of more junior consultants operating. However, when you stick this into the mix and adjust your figures, it really makes no difference at all. So that even that slight difference in the seniority of consultants operating on a Friday makes really very little effect to the Friday effect that we found. So the key, I suppose, to this work is the higher mortality on a Friday and not focusing on the weekend where case mix is radically different. 48 hours following surgery, we think may be key to this. And also when looking at the data, it seemed that frailer patients with a high burden of comorbidity are at higher risk, even higher risk of mortality at the weekend, which is kind of what you would expect. So what's behind some of these differences in mortality? Well, this is our paper published in JAMA Neurology, which looks at stroke care. And as well as just looking at mortality outcomes, we wanted to look at some of the process measures, some other indicators of quality of care at the weekend compared to weekdays. So again, we used English hospital data over a 1-year period, looking at a number of process and outcome indicators. So we looked at the proportion of patients who had a brain scan on the day of admission. We looked at the proportion of patients who had thrombolysis or clot-busting drugs. We had the proportion of patients who developed a pneumonia. We looked at 7-day hospital mortality for stroke. We looked at discharge to usual place of residence within 56 days. And this is perhaps a measure. If you're discharged back to the place that you were originally admitted from, then that's perhaps an indicator of successful treatment. And we also looked at 30-day readmissions, and again adjusted for many of the things that we're able to adjust for within administrative data. And I suppose what you're interested in seeing is the odds of receiving these treatments or getting complications compared at the weekend compared to weekdays. So looking at same-day brain scanning, you were less likely, if you were admitted at a weekend, to get a brain scan on the same day. You were less likely to get thrombolysis for a particular kind of stroke. You were more likely to develop an aspiration pneumonia. You certainly had a higher risk of death, around about, I think it was 1.18, higher odds of death compared at the weekends compared to the weekdays. You were less likely to be discharged home to your usual place of residence. Readmissions didn't seem to show anything at all in that. So here is a bit of work that looks not just at the outcomes, but perhaps some of the processes that may lead to those differences. Now I just want to show you a bit of new work before wrapping up, because Nick is waving things at me. This is some work very recent work, looking at obstetric care. And has been work done in the past, back in the 70s, looking at and finding a risk of perinatal death in children born at the weekend compared to weekdays. But we've taken a fresh look at this, looking at 2 years of data, looking at a number of outcomes, both for the neonate and the mother, and trying to tie it in with some staffing figures that we had. We adjusted, again, for some of the things that we're able to adjust for. We had just over 1 million maternities and 1 million births. The most common adverse events we found were perineal tears, where the lowest was maternal readmission. But this is the figure that you want. This is the figure you want to see. So these are the things that we looked at, and it appears that the mother was more likely to develop an infection following delivery. There was a higher risk of perinatal death if you were admitted for your birth at the weekend, a higher risk of injury to the neonate, and a higher risk of neonatal readmissions following discharge. So it does appear that our obstetric services have the same issue as some of the other services, that babies born at the weekend have an increased risk of being stillborn or dying in hospital within the first 7 days. How much time am I due to finish now, Nick, or have I got a minute or two? I'm due to finish. So, well, I will just talk very briefly about the impact. What's the cause around this? Well, Bruce Keogh's been looking at this. He's convened an expert committee. And some of the suggestions, much like we've suggested in the past, various staffing levels, variable staffing levels at the weekend, fewer senior consultants at the weekend, a lack of consistent support services, and a lack of community and primary care services. And his point is that it's not just about hospitals, it's about the whole system. And there is now a plan, a 3-year plan, to try and move to 7/7 working, looking at this 10 points around where to change services. And I do believe that CQC are going to be considering looking at weekend care in their inspection routine. I haven't really got time to tell you about some more stroke stuff, I don't think, but have I got time? No. Such a shame, because this is really nice. Are you sure I haven't just got 30 seconds? Go on. Right, okay. Oh, maybe I shouldn't, but this is so nice, and it did take me an hour to do the slide. So there's been a reorganisation of stroke services in London, and we've moved from about 30 different acute hospitals supplying care in London to 8. There was a very nice paper published just very recently looking at evaluating this and looking at mortality. I'm not going to tell you about that. I'm going to tell you about my work. We've looked at a number of indicators, those stroke indicators before and after the intervention, and you can see here, out of the 6, there's a very marked decrease in mortality. If you look at London, this is the red line, and if you look at the rest of the country, blue is fairly constant. But you can see at the time when the services were reorganised in London, mortality dropped considerably. What has happened at weekend care there? Well, if you look at the pre-intervention period and the post-intervention period, and you look at the rest of the country, you can see there's a big difference between weekday and weekend. This is the overall mortality with a 15% higher odds of death. If you look at post-intervention, you wouldn't expect to see anything in the rest of the country because not much has happened there apart from in Manchester. And again, the difference exists. If you look at London, pre-intervention, big difference between weekday and weekend. And what you'd expect to see after this intervention at HASU is a levelling up of that, because it's a 7/7 24-hour service. Do you see that? No, you don't quite see that. You do see a narrowing of the week and weekday effect, but it certainly doesn't disappear. So the jury's out. Thank you. I'm done.
That was a great introduction to the day. So now we have some time for questions for talk.
Just a very, very final point. Is the jury out because there isn't enough information or data yet to say whether 7/7 care is going to have the desired effect, or are we barking up the wrong tree?
Well, no, I think it's very important to look at the move towards 7/7 care. I mean, I picked the stroke example because it's a very nice brief intervention period where the whole service was reorganised in a matter of sort of 6 months or so. So it's quite nice to look at before and afterwards. I think with the gradual changes over a 3-year period, it might be more difficult to look at that, but it's certainly, I'll be keeping an eye on things to see whether the gap between week and weekend care has narrowed.
Any more questions? One at the back.
Do you get a day and night effect exacerbated on the weekend?
So we need to use the mics because this is being recorded. So
Do you get the DNA effect that exacerbated at the weekend?
Well, unfortunately, my data, I don't have times of admission on there, so I can't look at times. So I can't look at nighttime admissions using my data, but there may be other data sources that we can look at, local patient administration systems and other ways of looking at it. But I can't look at it, unfortunately.
Is there an ethical obligation to tell patients about these risks at the weekend alongside other risks with procedures?
Well, it's very interesting because on releasing these papers, there was a huge amount of media interest, and that's usually the first question that a journalist, or the last question that the journalist will ask you. Well, you know, my grandmother's coming into hospital on Friday. Should she be worried? And certainly with the elective surgery, the mortality is low. But I would say, rather than be worried, I would ask questions, perhaps, of your services. So patients are certainly aware of this now because it received huge coverage. I would say it generates questions, and I would. It's often difficult for patients, but if I were a patient, I'd like to have it demonstrated to me that there isn't an issue at weekends with weekdays at the hospital that I'm going to. So I'd like to be able to see some evidence. But that may just be me, who knows?
Great. I think we should wrap up the first session here, so please do join me in thanking Paul for his excellent contribution.